So I might get started. So welcome to today's webinar. I guess good morning, good afternoon, good evening, and we're so happy to have you join this webinar. On behalf of Dr. Lene Seidler, who's the co-moderator for the session, we're really excited to be able to share this webinar with you. Just a few housekeeping items to consider. So these webinars are organized through the Special Interest Group through ISBNPA, the International Society of Behavioral Nutrition and Physical Activity. And I haven't mentioned it, I'm Maureen Ashe, and I'm from Vancouver, Canada. There are lots of other webinars and recordings on the ISBNPA website if you'd like to have a look there. And as you've probably already noticed, that this webinar is being delivered via Zoom, and participants are muted by default. What the process will be is that we'll have 3 speakers who will each speak for about 10 minutes. And then what we ask is that you leave your questions until the end. Please, though, during the presentation, write your questions in the Q&A box, and then we will be able to answer them during the discussion. And Lene will be able to moderate those at the end of the session. And as well, too, at the end, during the discussion, you can raise your hand to interact with the panelists. So the name of this presentation is Equity Considerations in Evidence Synthesis, and it's presented from the SocioEconomic Inequalities SIG from ISBNPA. So we're really thrilled to be able to have 3 speakers, 2 from Canada and 1 from Australia. So Omar Dewidar is presenting on guidance for considering equity and evidence synthesis. Olivia Magwood will be presenting on stakeholder involvement in evidence synthesis. And then Kylie Hunter will be presenting on individual participant data analysis to examine different subgroups and populations. So just to let you know who our speakers are. So Omar is joining us from Ottawa in Canada. And Olivia is also joining us from Ottawa in Canada. And then Kylie is joining us from Sydney in Australia. So on that note, I will stop and then hand it over to our first speaker. So thank you.
Hey, thank you so much. So, hello everyone. As you guys have heard, my name is Omar Dewidar. I am a research associate at the Bruyere Method Center based in Ottawa, Canada. And I'm also a assistant convener as a part of the Campbell and Cochrane Equity Methods Group. And I'm also a medical student at the University of Toronto. So I'm very happy to be here. And today I'm going to talk to you about how to incorporate equity in evidence synthesis and share with you the guidance that is available. So in my presentation, I'm going to cover 3 main things. So first one is, what are health inequities? Second thing, how can we assess health inequities, and the framework that we advise people to use. And the third point is, how can you consider health equity in evidence synthesis and the guidance that is available? So I see this a lot in the literature, and you probably saw it also in the slides. Inequalities and inequities, what is the difference if there is one? So according to the WHO, inequalities are differences in health status or in the distribution of health determinants between different population groups. Now, the thing with this definition is it doesn't really consider whether that difference in health outcome is actually avoidable or not. And even if it is avoidable, is it acceptable? Can we live with it? Like, for example, having increased injury when you engage in extreme sports like skiing or paragliding, or is it unacceptable and unjust and should be considered? And we'll see examples of those unacceptable differences in upcoming slides. The term inequities is actually a bit different from inequalities. It has this moral or ethical dimension attached to it. So not only are the differences in health outcomes potentially avoidable, they are considered unacceptable and unjust, and they should be addressed. And if they're not, they could result in a population being socially disadvantaged. Now, the first thing that we think about when it comes to social disadvantage is low income or poverty, but that's not just it. There's several other factors that could result in a population being socially disadvantaged. And these factors, they form the acronym Progress Plus, which is a framework that we use as a memoir to identify disadvantaged populations or possibly disadvantaged populations. The first letter stands for place of residence, the P for place of residence. So here we're referring to living in rural versus urban areas. And an example of how that could impact health outcomes is that individuals living in rural areas have lower access to healthcare because of lower numbers of family physicians in those areas. So of course, this could have been avoidable if there was better distribution of resources or improving the number of family physicians in rural areas. And the difference would be considered unjust because some people cannot really choose where they end up living, or it suits their choice. Therefore, these differences in health outcomes because of that difficulty in access to healthcare would be considered unfair or unjust. The second letter, R, stands for race or ethnicity. Now, we also group with that culture and language, but of course, those are very different terms. And an example of that would be that in India, there's certain children from certain castes are less likely to be immunized, and that would result in them having worse health outcomes. So when the health equity consideration here would be that when recommending immunization for children, you should really have considerations for children from these castes and maybe potential alternatives. The third letter is O, and that stands for occupation. So an example here is that workers in certain occupations, such as coal mining and other high-risk occupations, have an increased risk of work occupation-related injury. So these workers should have better access to emergency care in case they get any injuries to reduce that excessive risk. The G in progress stands for gender or sex. An example here would be that in many cultures, having a son is more preferable than a daughter. So when, for example, a physician is recommending an ultrasound, that could result in sex-selective abortions. So physicians should potentially consider the culture and beliefs of the parents when recommending an ultrasound to avoid exacerbating these health inequities. The R in progress stands for religion. So an example here would be that there's way lower immunization rates among Amish populations compared to the non-Amish populations, and that potentially could lead to outbreaks of disease. So when it comes to developing public health policies, there should be considerations for such populations to avoid such events from happening, and them also having higher rates of mortality. The E stands for education. So an example here is that lower maternal and paternal education is associated with reduced rates of breastfeeding. So when considering, let's say, nutrition counseling interventions for parents, education level should be considered to ensure that these individuals benefit as much as possible from the intervention and their children have the best health outcomes they can possibly have. The first S in progress stands for socioeconomic status. So that's the income. And an example here is that individuals with low household wealth tend to have less likely own malaria bed nets, and that decrease in ownership could potentially lead to, again, worse health outcomes because of malaria. And so the solution here would potentially be governments providing subsidized bed nets for poor households, or maybe provide other alternatives that could suit their needs. Then the final S in progress stands for social capital. So here we mean like social support. And the example here would be that socially isolated people are actually 2 to 3 times more likely to have mortality, to suffer from mortality than those with social networks and sources of support. So again, to reduce that excessive risk, we should have some programs or interventions in place for these vulnerable populations. So one thing that's very important to consider when thinking about health equity is that, and using frameworks, is that, and especially also like including progress plus, is that these factors don't necessarily indicate disadvantage. They're just prompts rather than absolute statements about the risk of disadvantage. Therefore, there's a certain level of judgment that comes into play when using them. So we suggest that researchers consider theoretical approaches to each of the factors, as well as their expected influence on health outcomes. So in addition to progress, there's the plus, as I've mentioned it before. So this plus allows for consideration of additional context-specific factors, but they're generally categorized into three groups. So you have personal characteristics that are associated with discrimination, such as age, sexual orientation, features of relationship that could lead to health inequities, such as having smoking parents or being excluded from school. And then the third category, which is time-dependent relationships, such as being in prison or leaving hospital respite care. So times where an individual could be at a higher risk of facing adverse effects or adverse outcomes. So now that I've went over how to assess health inequities, and we know what health inequities are and what they look like, how can we use this when developing evidence synthesis? And it all starts off by applying from the beginning, from the research team, and we could apply progress plus from there. When we think of the diversity of the team and the composition of it, and it's very important that we want to think about involving the individuals within the team in EDI training activities, such as the Sport Evidence Alliance's reflective EDI exercise or Indigenous cultural safety training, and getting the individuals of the team to do this kind of training not only builds trust and fosters a safe space for meaningful discussion, but it also ensures that everyone's on the right page and in the same one. The second step would be when developing the research question. So the review authors could decide to focus on populations experiencing inequities. And again, that's across the Progress Plus, so they can use the Progress Plus framework to define these populations. Or they could consider to do a subgroup analysis across one of those populations of interest. But it's very important that review authors, again, supplement these decisions with an a priori definition of how the intervention is expected to influence health equity for those populations, and also restrict or adjust inclusion criteria and study design to ensure that they assess the population properly. The third step would be in the identification of evidence. So reviewers might need to consider searches in social databases or other interdisciplinary databases from low middle income countries to identify relevant evidence that could inform equity decisions. And that also, again, depends on the research question. They could also need to look into grey literature and government or non-governmental websites that could have relevant information. But when conducting the search, they should also think about the search terms that they're using and make sure that they're going to capture equity-related content. And there's several validated filters out there, but they should really assess whether the search filter applies to the question that they're looking at or not. So the fourth step would be in data collection. And so here, this is a very important step because reviewers need to plan the variables of interest for the data collection process and think about how they could use Progress Plus to extract that information. So you really need this information so you can actually do an evidence appraisal and analysis for populations experiencing inequities. And you could supplement that with capturing elements related to study design, to evaluate the nature of participant inclusion or exclusion and how that influences the applicability of the results. Then comes the next step, which is analysis and critical appraisal. So critical appraisal involves assessing the study design factors that we captured earlier in the data collection stage, factors like recruitment, attrition, that could potentially influence health equity. So if you're realizing that the certain populations are dropping out more than others, then there's potentially a health equity issue there that needs to be addressed. And of course, the approach for appraisal would depend on the type of evidence that's being investigated. Another thing that review authors should do is actually consider whether there's baseline imbalances across the progress plus factors for quantitative evidence, and also when looking at qualitative evidence, they could look at quotes across populations defined by the progress plus characteristics. And when it comes, of course, to quantitative analysis, several methods could be used, including subgroup analysis, moderator analysis, or meta-regression. But again, that all depends on the question and the evidence at hand. But the most important thing for any analysis is that it has to be predefined, accompanied with a rationale, linked to an analytical framework, and transparently reported. Now comes the interpretation of the findings. So the principles of interpretation include evaluating who was included in the studies and judging if they were properly represented in the studies. And second thing is looking if there were any differences in recruitment, retention, or differences in effect. And what we suggest is that using the GRADE approach, GRADE stands for Grading of Recommendations, Assessment, Development, and Evaluation, could really help reviewers grasp all of that together, because the way that the approach is structured is that it helps you make an assessment on the findings based off of directness to the population of interest, consistency across studies, imprecision of findings, and risk of bias. And this is mandatory for Cochrane reviews, but we see it's very rarely that people use this outside of Cochrane. When it comes to reviews, because it's a lot of work, but it's very worth it, especially when it comes to equity. And then the final thing is adhering to equity reporting guidelines. So when it comes to reviews, we've published, or members of our team have published, the PRISM equity guidelines. And these guidelines really lay out how to report across the study sections for equity to make sure that we have a transparent and informative research that could actually inform the next stage, which is guideline development and developing recommendations. So putting it all together, like this is what it looks like. And actually this paper has been published in JCE. The thing that I didn't really talk about, but it's very, very important, and my colleague will be talking about, is the importance of actually engaging stakeholders throughout all stages of the review process, because without engaging relevant stakeholders, we wouldn't be able to know what's actually clinically relevant and who is actually disadvantaged, and how to really solve these problems. But I would say from all that I've mentioned, the three very important points to really consider and are relevant to every single type of review is considering equity in the question development. So would you focus on a specific population or do a subgroup analysis across them? How are you collecting evidence for equity? Are you capturing the description of the patient characteristics? Are you capturing differences in effect and analyzing evidence? So how are you going to analyze it, and how are you going to assess differences in effect and attrition and recruitment? Thank you very much for listening, and have a great day or evening wherever you are.
Thank you, Omar. I think that was such a nice introduction to equity and evidence synthesis, and I think my presentation is going to build really well on some of the topics that you've brought up. So hello, everybody. My name is Olivia Magwood. I'm a PhD candidate at the University of Ottawa, a research associate at the Bruyere Research Institute, as well as a PhD. And so today I'm going to be presenting to you on behalf of the MUSE Consortium, or the Multi-Stakeholder Engagement Consortium. And so who are we exactly? Well, we're an international consortium of individuals and organizations that were established in 2015. There's now over 140 members in over 30 countries around the world. And we've come together over a common interest in stakeholder engagement in research and health practice guidelines. And so we currently have 2 funded projects, one of which is coming to the end of this year, which is stakeholder engagement in guideline development. and the project that I'll be focusing on today, which is stakeholder engagement in evidence synthesis. So a brief overview of what we are aimed to do. So we're going to be doing a series of systematic reviews that focus on different elements of stakeholder engagement in evidence synthesis. And our goal here is to develop a comprehensive set of guidance for reviewers, for systematic review authors, so that they know who to engage, when, and how throughout evidence synthesis. And so this guidance is going to be coming out over the next few years. And so what you get today is a little bit of a sneak peek as to what some of that content may be. And Omar has already so nicely highlighted why we should engage stakeholders. It's so that we can better consider equity in our evidence synthesis work. These folks are able to help us, refine the scope of the work that we're doing, identify the keywords and the topics that we should be covering, and they can even help us interpret the evidence and influence review findings, which will ultimately contribute to a more equitable evidence base. And I just really love this quote on the slide that says, the insights that stakeholders provide are the key to ethical decision making, which is the only sustainable solution to inequities. And so who are stakeholders, and who might you consider engaging when conducting a systematic review or an evidence synthesis product? So we define a stakeholder as interested people and groups who are responsible for or affected by health and healthcare related decisions. And through a review of existing frameworks and multi-stakeholder meetings, we have developed an 11 Ps framework. So these are 11 categories of stakeholders that you might consider engaging in your evidence synthesis work. You might see some familiar ones up on the screen, such as patients, caregivers, public. And so these are the groups that the Cochrane collaboration typically labels as consumers. And there's already quite a lot of work that's gone into engaging consumers in evidence synthesis. What the Muse guidance hopes to bring is some additional help and additional thoughts behind why you might want to engage additional stakeholders or other people in evidence synthesis, and how this might actually promote the uptake of equitable evidence later on. Now, despite the fact that I am using the term stakeholder in this presentation, the Muse Consortium actually recognizes that the term stakeholder can be quite problematic, and particularly in the Canadian context that I live in. So this term stakeholder has a colonial history whereby it was used to describe a person who drove a stake into the land that they were stealing from an Indigenous people. And continued use of the term can be seen as quite disrespectful to Indigenous people. So you may notice that throughout this presentation, I'll put in some other terms and words, and this is the language that we are trying to shift towards. So other options for stakeholders, if you choose to describe them, could be partners or knowledge users, constituents, or interested and affected parties. This is a decision that any evidence synthesis team would have to make at the outset, and the best way to go about this is just to ask your partners, how is it that you'd like to be referred? So next, what is it that I mean by engagement when I say stakeholder or engagement of partners? So we have this definition here of an active partnership between stakeholders and researchers in the production of new healthcare knowledge and evidence. And it can also be described as collaboration or involvement or partnership. And in the evidence base, a lot of these terms are used pretty interchangeably. We've done a lot of thinking about, well, what do we mean by the level of engagement that somebody might be involved when you're doing an evidence review? Here on the left, we have Arnstein's ladder of participation that may look familiar, which forms really the basis of our thinking behind this work. And really what it comes down to is, at any given moment, are we asking a partner to come to a decision with us and act as a decision maker? Or are we consulting them for some advice or some feedback that we then take into consideration to inform a decision? You've already heard Omar mention the importance of picking the right stakeholders to involve in your work. So we have a publication that came out last year about factors to consider when trying to identify and invite individuals to be members of your partnership. And you'll notice one of the key things that we identified is inclusivity, or equity, diversity, and intersectionality. And I'd like to remind us all that, as Omar mentioned, we can use Progress Plus as a mnemonic to help us guide our question generation or our analysis, but we should also take these factors into consideration when thinking about the people that we want to involve in our work. There are also some really great resources available that can help support equity-centered engagement. And so the work on this slide actually comes from a group from McMaster University called the Public and Patient Engagement Collaborative. And although this resource is not specific to evidence synthesis, they've put together a really lovely compendium of resources to help researchers think about how to make their engagement equitable. And it begins by thinking about, how can we prepare to engage equitably and plan for engagement that puts equity at its center, and also gives us some tips and tricks for how to engage with particular populations and strategies that we can use in making decisions to foster equity. There's actually going to be a really great webinar presentation on this resource specifically next week. And so to kind of complement all the existing thinking and theoretical ideas that have gone on, the current Muse project actually works with what we call the active framework. So this was a framework developed by Alex Todd-Hunter-Brown and is working with the Cochrane Consumer Group. And it helps systematic reviewers plan for engagement throughout all the stages of a review. And it looks at their tasks and also their roles. And it's a really nice complement to the existing reporting guideline we have for stakeholder engagement called GRIP 2. And so you may be wondering, at what stage during a systematic review or during an evidence synthesis can we engage stakeholders? And the reality is that it can be at almost any stage, beginning right at the conception of the project, acquisition of funding, through to the development of the protocol, searching for your evidence, summarizing it, and presenting it for dissemination. There are many ways that you can do this, and I think a key learning from some of the Muse work that's gone on so far is that the best thing we can do is ask stakeholders or ask our partners, what is it that they'd like to do and what is it they want to get out of their engagement? Some folks want to be, full review team members or co-authors on the publications and truly participate in all of the elements of a systematic review. But others are much happier being on either steering or advisory committees where they provide some strategic direction or advice to a review team to help ensure that the evidence remains relevant, and this helps address barriers to eventual uptake of the evidence base. We also have options for gathering information from populations or from our stakeholders. And so this can be done using surveys such as Delphi's, or even doing workshops and community consultations. And so here on the slide, I'm just trying to present a really nice example of how this could be done in practice. So beginning at the top left, this is an example of a Delphi that actually asked members of a community, in this case it was people with lived experience of homelessness, what topics were most important to them and where they felt evidence needed to be. So we actually went out to the community, had community partners, and asked the people who were going to be most directly affected by the evidence base what topics were most important to them. We then developed a systematic review protocol based on the findings of that Delphi, and we invited members who acted as representatives of those communities to act as full review team members with us. And we gave them the term community scholars with lived experience. They played a really foundational role in the development of the protocol, including the selection and the ranking of our outcomes. We then conducted a series of systematic reviews and successfully published these. And the community scholars who were involved in this work really helped with the interpretation, so thinking about the meaning and the eventual use of the evidence. And this all came together in a one-day homeless health research summit where we invited additional stakeholders such as policymakers and program managers to be presented the evidence and to discuss the implications of it all. And then using all that evidence, we actually developed Canada's first clinical practice guideline for the care of the homeless and vulnerably housed populations. And we included people with lived experience of homelessness in our dissemination activities, including as authors on the clinical practice guideline. And so, in summary, some of the key messages that I'm trying to express today are that stakeholder engagement can improve the relevance and uptake of a systematic review and of the research evidence. And within the Muse Consortium, we've identified 11 types of stakeholders or partners that review teams should consider. These folks don't need to be engaged with the same level of intensity throughout the whole project. There are varying levels, and we should ask stakeholders themselves what their preferences are and how they want to be engaged. To facilitate that, we should commit to a set of principles that kind of guide our engagement. And this is something that Omar also alluded to, that how important it is to set up your review team at the beginning. And over the next few years, the Muse Consortium aims to produce guidance for review authors on who should be engaged in evidence syntheses and when and how they should be engaged. We're really excited to share some of this over the next coming years. If you're interested in learning more or keeping up with what we're doing, you're welcome to contact Jennifer Petkovich, who is the coordinator for the Muse Consortium. And so now I'm really pleased to hand this off to Kylie to continue the discussion.
Great, thanks so much, Olivia. That was a really interesting presentation, and Omar. So can everyone see my slides okay? I guess speak up if not, otherwise I'll jump right in. So my name's Kylie Hunter. I'm a senior evidence analyst for the Next Gen Evidence Synthesis team at the NHMRC Clinical Trials Centre, University of Sydney. And I'm also associate convener of the Cochrane Prospective Meta-Analysis Methods Group. And today my presentation will focus on next-gen evidence synthesis methods, in particular individual participant data analysis, to examine different subgroups and populations. I'd like to acknowledge and pay respect to the traditional owners of the land on which I'm presenting from, which is the Gadigal people of the Eora Nation. And I just want to begin by asking people to think about, why it is that we conduct medical research. Feel free to type any comments into the chat, or just have a think about, what is our ultimate end goal when we are conducting medical research. Okay, so hopefully you were sort of thinking along these lines. I think we ultimately want to inform clinical practice and policy in a way that will lead to improved outcomes for each and every individual patient. However, in reality, research often tells us what works best for those most likely to be in a trial. So commonly white males with a high income. And the findings from such research is then generalized across population groups to inform treatment decisions. However, effectiveness and safety of interventions may differ among population subgroups. So, for instance, by ethnicity or socioeconomic position. And so therefore, it's crucial to assess these differences so that we can ensure healthcare meets the needs of all population groups. So in my presentation today, I'm going to focus on how we can address these equity considerations using next-gen evidence synthesis methods, including individual participant data, but also prospective meta-analysis. And throughout, I'll be referring to the Top Child case study to illustrate some key messages. So briefly, Top Child is bringing together all trials on early child obesity prevention, with the main aim to find out which intervention components are most effective and, importantly, in which populations. And we know that child obesity is a major health equity problem. It's more prevalent in underserved populations. So it's really important that we are targeting the right groups here. So how could we address equity considerations in health research? Well, we could conduct trials that are targeted specifically to priority populations. And this is very important indeed, but this is often limited by recruitment difficulties. It's difficult to get a sufficient sample size, so there may be power issues. Another option is to conduct traditional evidence synthesis methods. And again, we have an issue here of potential limitation of aggregation bias and power issues as well. So what I mean with traditional evidence synthesis, these are systematic reviews that are typically considered at the top of the evidence hierarchy, and they're widely used to inform healthcare policy and practice. But as I mentioned, there are several limitations and potential sources of bias associated with these traditional meta-analyses. And one of these key problems is that analyses are limited to what can be extracted from publications. So we have all these colourful participants participating in trials, but then their data is summarised into publications, and then we combine these publications. This gives us an average effect estimate. So all of the diversity in colour is lost, and we're left with this average grey person. And such analyses are prone to aggregation bias. So this occurs when it's wrongly assumed that associations between aggregate values are representative for individual subjects. So essentially, these average results hide the differences in effects between different populations. So what can we do? Well, individual participant data meta-analysis is a potential solution here. So this involves the central collection of raw data for each participant in the original trials. So as shown in this little snippet here, what we mean, each row in our data set represents a participant, and each column is a different variable. So this method allows us to maintain that diversity, those colours, so that we can conduct richer analyses. So the key advantages of IPD, or individual participant data, so it is regarded as the gold standard for meta-analyses because it enables us to obtain the most comprehensive and current data, including data that are unreported or unpublished. We can also conduct in-depth data quality and integrity checks. Some harmonisation is possible across studies, and again, it leads to increased statistical power. And really importantly, it allows us to take more complex analyses, such as subgroup analyses by socioeconomic position, for example. And so this enables us to explore differential effects across priority populations. Therefore, it can help us to answer the question, which interventions work for these priority populations? So in this way, IPD can be a really powerful tool to increase equity in research. So TopChild is conducting an individual participant data meta-analysis, and this is aiming to evaluate effectiveness of interventions overall, but also we're exploring several key subgroups to see if there are any differential effects among at the individual level and the trial level. So, but one challenge we have faced which is common across all reviews, is of course we are limited by which trials are conducted on our research question and the data that are available. So to date, we have 50 trials included in the TopChild collaboration, and these are set across 17 countries, so quite widespread, which is great. However, 88% are set in high-income countries, although there are 6 in middle-income countries. But we really need some more diversity in trial location here, because we do know that childhood obesity is an increasing population problem among lower and middle-income countries. We've also found with our TopChild trials that only around a quarter target these specific priority populations, so lower socioeconomic background populations and those of specific cultural backgrounds. The remainder of targeted universal populations. And so while all of these trials are important, again, we know childhood obesity disproportionately affects these priority populations. So we really need to make sure that future trials are reaching the populations that really need it the most. Another key challenge is that socio-demographic variables are often either not collected or if they are, they're not fully reported, and they can be assessed in many different ways. So for top child, we are collecting several socio-demographic variables. Some of these are listed here, so things like household income, ethnicity, employment status, etc. And with the example of race and ethnicity, each box here is representative of a trial in top child. So it's great. A lot of trials have collected this information. However, you can see there is quite a lot of diversity in how they've collected this information. And so it's really then difficult for us to combine this information for analyses. So a potential solution here is prospective meta-analysis, or PMA. And the key feature of this methodology is that studies are identified as eligible for inclusion in the meta-analysis before the results are known. So as the figure shows, studies can be included early on in the planning, recruitment, or even at the data collection stage. But the key advantage of this is that trialists can agree to collect common core variables and outcomes early on and use similar or identical measures, which makes it much easier to facilitate, to combine this evidence if it's all harmonized. But on a broader level, I think it's really important we have some standardization at both at national and international level. So we need to standardize definitions and measures for collection of core socio-demographic variables. So there's already an initiative called COMET, which focuses on harmonizing outcome measures. I think it'd be great if we could have something similar for socio-demographic variables. And there are some initiatives that do exist already. So for instance, there's ECHO, which is a large consortium in the US, and their data harmonization working group has done standardization at the national level. Also, there's a website called Maelstrom, which provides methods and expertise to support harmonization for collaborative projects. But I think I liked this quote from the WHO report. What we really need is to establish national and global health equity surveillance systems with routine collection of data on social determinants and health equity. So just to finish off the top child story, I guess we're hoping to complete our first analyses this year. And what our collaborative vision is, we've tried to demonstrate this with Duplo or Lego. So on the left here, we have all these colourful components, which we are working through and sorting out. So sorting out what interventions are made of and what our different populations are, with our end goal to have these tailored interventions for specific populations. So working out what works best in whom. So I'd just like to leave you with a few key lessons. So first of all, look for collaborative opportunities. Can you conduct prospective meta-analysis? Are there a number of similar trials going on in a specific field? And a good way to find these trials is to search clinical trials registers. And we have published some guidance in the BMJ on how you might best do this. It's also important, as I mentioned, to collect core protocol elements, demographic variables and outcomes wherever possible, and use common measures. Also, in your evidence synthesis projects, be inclusive with participant eligibility and collect data on vulnerable populations, and plan for further data sharing, and also improve reporting on health equity. So as Omar mentioned, there is PRISMA Equity Extension that guides how to report these best. So I think that's it from me. Thank you, and happy to answer any questions that you might have.
Thank you very much to all our speakers. I think those were really great Really, really great talks. And the floor is now open to questions. While we wait for questions to come in, I have a lot for you. So I may just take the privilege of the moderator to start you off. The first question I have, I think, is for all of you, which is, so you all work in evidence synthesis and think a lot about equity. But I assume you're limited, and I think Kylie touched on that, by what is actually reported in individual studies. So I was wondering, from your work, trying to synthesize evidence that is out there, what are your key lessons and key things you would like to see improved in how individual studies are run with regard to evidence synthesis? And that's a question for all of you. So happy for all of you to answer. Olivia, did you want to start?
Sure. Thank you. I think that's a really nice and interesting question, and I'm sure others have faced the same challenge as me, but one of the trickiest things about attempting to do an evidence synthesis and stratifying results by characteristics such as Progress Plus is that most studies don't use that mnemonic to report their data. And so most of the time we just don't have the data available to us to do the types of stratified analyses or subgroup analyses that we'd really like to do. And I'm sure Kylie can comment more on this about the importance of having access to that individual patient data and those characteristics to help you do those types of analyses.
Great, thanks, Olivia. Omar, did you want to add to that?
Yeah, so, well, as Kylie mentioned, it's really important to think about equity in primary studies before we even really start preaching it at reviews level, because we can't do anything without the data. And we have an equity extension for the consort checklist. We developed that in 2017. And right now we're working on the strobe checklist for observational studies. And I think that will have a very great addition to the literature. Because most social demographic data is being reported in observational studies. So we should be, well, there's an interim guidance already out, but we should be putting it out there in the next couple of years. But again, reporting is different from conduct, and this idea of designing trials or designing studies with the intent to collect health equity information. That's something that I feel like is not being done enough. And one of the things that we're trying to do right now with the strobe is actually we're doing this qualitative assessment of observational studies, looking at what is the motivation behind assessing health equity. So we kind of selected a bunch of studies that we think are health equity relevant based on Progress Plus. And we're looking at what motivated authors to really look at equity. And then I think this is going to be a very valuable piece to understand what are authors looking for and why they're doing what they're doing, and how can we tailor guidance to really accommodate that. IPD all the way. I'm a big fan.
Great, thanks so much. That's very insightful, and very much looking forward to this upcoming work. Make sure to share it with us. Kylie, did you want to add to that?
Just collect that data and try and do it. Have appropriate rationale why you would collect specific things, but according to Progress Plus, and try and harmonize it as much as possible to make our job easier as doing evidence synthesis.
Right. There's a question in the chat, which is, are there any plans to update Progress Plus and Prisma Equity, as some of these frameworks have been developed over 10 years ago?
That's a great question, because a couple of days ago, I was thinking about we really need to do a scoping review of all the frameworks available to assess social determinants of health or health and equity. And I think that's very, very needed. So far, from every time we try to do a study on health equity, we have been looking at what's been out there. And the thing is, Progress Plus, I think, it's been it was well developed because it was done with rationales again on how to on these selection of the factors. But it's very vague, especially when you deal with plus. It's very you can put anything in there almost. So it's a basket. That's what we call it. I think that future work should be really informed by, the current status of health equity and all the issues that are popping up, especially with COVID. New things have been popping up. But progress has been working well for us, but still, I think there's a lot of area for it to develop. And Prisma Equity, well, they did update the Prisma, so I do hope that we can update the Prisma Equity as well. And maybe, that's going to be problematic for a lot of the reporting guidelines, but definitely equity, because it's becoming more and more important and everyone's looking for it.
Great, thank you. While we wait for more questions in the chat, I have a lot of other questions for you because they were such good talks. My next question is for Olivia, which is, so when we've tried to engage stakeholders previously, particularly for groups that where we have those equity considerations and concerns, we often have dealt with a lot of barriers. So, for example, different educational levels, health literacy, different languages being spoken. And I found your example of engaging people that have experience with homelessness really relevant and impressive, because I would imagine that there are a lot of barriers to engage these kind of participants and to ensure that they retain motivated. And so it'd be great to hear a bit more from you on how you did that and what kind of recommendations you have there for other researchers.
Thank you. That's such an excellent question. And you're so right. It can be really challenging to do stakeholder engagement. And I think that's something that a lot of people should be aware of at the outset of doing a review, is that you will naturally have, some additional challenges, additional time, might have additional costs. So there's a lot to think about. And particularly when we're dealing with, vulnerable or disadvantaged or marginalized groups, they often face a lot more barriers than the rest of us. And so in that particular project, what we found was so helpful in keeping that community engaged was having a point person, so a dedicated person to help coordinate and manage stakeholder engagement. And I think what was so important about this person is that they needed to be less of a researcher and more of a community partner. And so meeting or having phone calls with our community scholars with lived experience that were outside of the project meeting times, or giving information to them in a different form than an academic presentation or an academic abstract, was really important. And so on that particular project, that's the role that I played as the liaison between our community scholars and our research team. And I think, establishing those relationships and building trust over time really helped with the sustainability and made them want to work with us and stick around.
That's great. And that's very impressive how you managed to do that. Great. And we have another question in the chat, which is whether you have any examples of how you've used Progress Plus characteristics and data extraction. I think, Omar, you've just given an answer, but if you wanted to maybe briefly talk us through one of that.
Yeah, so in the process of developing the reporting guidelines, or just generally understanding the extent of reporting of equity and guidelines, observational studies or trials, what we did was we used the Progress Plus to look at how equity is being considered in the study design, analysis, and interpretation of the findings. So that's kind of a methodological assessment. So what we do is we use progress as it is, as I've defined it in the webinar, and then plus we would subcategorize it, because again, it's very vague as it is right now. Of course, the best way to subcategorize it is with engaging relevant stakeholders. Don't do it yourself. And then we look at the studies or whatever literature we're assessing. But I think the question was also relevant to like a systematic review. And I'm trying to pull up this Cochrane review that we did on social media interventions. We did that, and yeah, there it is. Yeah. So here we did have an equity lens to it, and Olivia has done a lot of this as well. She has some work where she found equity evidence. Of course, it's a bit difficult, as we've said, that sometimes you don't find anything, and it's challenging. But yeah, we're trying to work our way from the bottom up, I would say.
Excellent. Thank you. And I have another question for Kylie. We're talking about stakeholder engagement. Do you engage stakeholders in the individual participant data meta-analyses, and what are the challenges with that? Because that's such a complex methodology.
Yeah, specifically for Top Child, we do have 2 consumers, but we are struggling a bit with engagement because, as you say, it is a complex methodology and it's a bit intimidating to have a consumer just attend our regular meetings with all the professors and researchers. So I think, yeah, it's really great advice, Olivia. We need to maybe have someone that's just dedicated to fostering those relationships. We've had in another large IPD that led by you, Lene, we have had a great consumer representative who's had a background in health, and so she's been really useful to provide input. So it's just about, I guess, finding someone, that's got the right. Maybe it's more about us needing to nurture them. I think their involvement. Yeah.
Great, thank you very much. And maybe one last question for all of you. So one thing I was wondering is what kind of research questions do these equity considerations for evidence synthesis apply to? Is that something we need to have certain focus questions for, or should we really start looking at all research questions through an equity angle? Very broad, just to finish you off.
Yeah, that's a great question. Honestly, we believe that equity is relevant in anything and everywhere. It's just a matter of whether you know it or not. I think so. Things where there is evidence where equity is a problem, or there isn't an equity available, then I think authors should have that construct or mindset to really try to address them and come up with frameworks and logic models to how they believe that the intervention or whatever they're trying to do is actually going to reduce it or impact it. But of course, it's a bit more difficult with areas that are a bit more unknown. But I feel like at the stage that we're at right now, there's a lot more denial than lack of knowledge. So, and again, like, I think we've reached a point as well, like when you look at major funding organizations like CHR, like they don't care what kind of project you're on. You have to look at sex and gender. So I think this is, of course, an equity consideration. And I think that the same approach should be applied across other factors as well. And we're seeing this more and more now with race and ethnicity, where especially in the US, where racial inequities are a big thing. So yeah, it's all coming to light. But I believe, to answer your question, equity should be considered everywhere.
Great. Unless one of the other speakers want to add to that, otherwise I will wrap up in the last minute we have. Kylie,
I was just going to add that I agree entirely that we both must respond.
Yeah, Omar's got it. Equity in everything.
Excellent.
Yeah.
And I think that's a really nice way to finish this webinar. Thank you so much. I think it'll be a great resource for people to come back to. I think you've reminded us all how important it is to think about equity in all the research we do, to report it well, and to incorporate it into evidence synthesis, and shown us some great tools on how to do that. So thank you so much. That was really excellent. I hope you have a lovely day, evening, night, morning, wherever you are.
Excellent. Thank you.
Thank you.
Thank you so much.
Bye-bye.